Picture this. You're cutting vegetables, you accidentally slit your hand, you're bleeding, and you have created a wound. Grab your piece of paper and let's go. Hello and welcome to MK's Medical Review Series. My name is Dr. Moses Kazevu. This is a series on my YouTube channel where we look at medical topics in depth. Today we're going to be looking at wounds and wound healing. If you haven't yet subscribed to the channel, please hit the subscribe button, hit the bell notification icon to be receiving notifications of such videos every time I post. Tell a friend to tell a friend. We are doing lectures on the channel, and let's go. Here's a question of food for thought that I've actually put for you before I actually give you the warm-up question. You know that pain is one of the cardinal signs of inflammation, a very necessary step in wound healing. But yet, it also causes a delay in wound healing. But however, if you actually look at it, why is it that individuals that have the lack of ability to actually feel pain still have their wounds healing slower? If the thing that is delaying the wound healing has been removed, why do their wounds heal slower? That's just the food for thought that you may actually discuss in the comment section below. Here's a warm-up question, which is a true or false question. Factors that delay wound healing include A, poor blood supply for nutritional support or for nutrition support, B, infection, C, poorly controlled diabetes mellitus, D, all above except C. So what exactly is a wound? So there are two things that I want you to be able to distinguish: a wound from an ulcer. Recall that a wound is pretty much a break in the integrity of skin and tissue, often associated with disruption of structure and function. Notice how in my definition, I'm not saying a wound is a wound. That is, no. It's a break in the integrity of the skin or tissues, often associated with disruption in structure and function. Then when I talk about an ulcer, this is a disruption or discontinuity or a break in the continuity of the covering epithelium, which may affect the skin, the mucous membrane, and associated with microscopic death of tissue, associated with necrosis. So ulcers are actually a type of wound. I will do another lecture on ulcers on its own, so don't worry much about that. So how do we classify wounds? They may be classified as simple versus complex. So simple is where only the skin is involved. Complex is involving other organs and other structures like vessels, nerves, tendons, and even bones. Wounds can alternatively be classified as tidy versus untidy. You may classify them as closed wounds versus open wounds. Example of closed wounds include contusions, abrasions, hematomas. Then, of course, open wounds include incised wounds, lacerated wounds, crush injuries, penetrating wounds. Alternatively, you may also classify wounds as clean wounds, clean contaminated wounds, contaminated wounds, and dirty wounds. This is a classification that I will dwell so much on because it helps us now remember which types of wounds do patients actually need prophylactic antibiotics, to which type of wounds do they actually need therapeutic antibiotics. So, the classification of wounds, so that's the surgical classification that I'm going to be based on. The first class is the clean wounds. So these ones have a minimal risk of infection, less than 2%. You mostly get these wounds from surgically incised, or these type of wounds from surgically incised injury. So this is with complete adherence to all septic conditions, or rather aseptic conditions, without any breach in any hollow viscera. So for example, if you're undergoing a thyroidectomy, a heniorrhaphy, heniotomy, lumpectomy, excision of a lipoma, surgeries of the brain, the joints, the heart, or even other transplants, which are pretty much no inflamed organ that is involved, no perforation of any viscus, then these are denoted as clean wounds. So there is no need for antibiotics when you're dealing with clean wounds, except in individuals where you have some immunosuppression or patients that have prosthetic valves. Of course, in our setting here, we usually give routine prophylactic antibiotics, which shouldn't be the case because we are usually now creating other problems like resistance. Then you have the clean contaminated wounds, which typically have low risk of infection, 10%, And usually these are wounds with entry to hollow organs, but this hollow organ is not inflamed. And entry into an abscess cavity with minor breach in the aseptic procedure, mild spillage of intra-abdominal viscous, so it could be an appendectomy, bowel surgeries, gallbladder, biliary, pancreatic surgery. So here you need some prophylactic antibiotics to be given to the patient. Then with contaminated wounds, there's a high risk or higher rate of infection. That's about 15 to 30%. So these are going to be occurring where there's a major breach in the aseptic condition, even without any entry into the abscess cavity or any hollow viscous. This could be, for example, acute abdomen conditions or even an open, fresh, accidental wound. So here you need the antibiotics for treatment. They are therapeutic antibiotics aimed at treatment and not really prophylaxis. Then we have the dirty wounds or infected wounds. These have a very high risk of infection, 40 to 70% risk. So these are going to be grossly infected with pus. It may be with entry into an abscess cavity, such as a gangrenous bowel, for example, an abscess drainage, a pyocele, empyema gallbladder, even fecal peritonitis. Again, here you're going to be giving treatment for the antibiotics. Then how exactly do wounds heal? Before actually going to the process of wound healing, remember that this is a very complex procedure. It's going to be involving different processes where you're going to be coming together to achieve anatomical and functional integrity of the disrupted tissues. So remember that healing can happen in two main ways. It can happen through regeneration, where the tissue that was damaged is replaced with the natural tissue that's supposed to be there, or it could be repair, where the damaged tissue is going to be replaced with a fibrous scar. So it occurs when you have lost the regenerative capacity of the stem cells, or the stem cells themselves have been damaged. So remember that the cells in the body are largely divided into three main types of cells. You have labile cells, which are also referred to as continuous dividers. You have stable cells, which are also referred to as facultative dividers or quiescent cells. And you have permanent tissues, which are also referred to as terminally differentiated cells. So the labile cells are constantly in the cell cycle, so they are constantly regenerating. Examples include small bowels and the large bowel. The stem cells are found in the mucosal crypts. The skin, the stem cells are found in the stratum basale, the basal layer of the skin. Bone marrow has the hematopoietic stem cells. The lungs have the type 2 pneumocytes, which act as stem cells. Then the stable cells are only going to be entering into the cycle when they need to. So for example, regeneration of the liver by compensatory hyperplasia. If you resect the liver partially, then each hepatocyte is obviously going to produce additional cells, and then it goes back into this quiescent state. Then the cells of the proximal renal tubule are also considered as stable cells. Then the permanently divided tissues or permanently differentiated cells, these are going to be lacking significant regenerative potential. So once these are injured, they're going to be healing by repair. For example, cells of the heart, the myocardium, the skeletal muscles, and the neurons. Remember that healing is going to be an organized staged pathway involving many cells. It's going to involve neutrophils, it's going to involve macrophages, it's going to involve lymphocytes, fibroblasts, as well as collagen. Before I actually go into the process of wound healing, I just want to address the types of wound closure. So there are three main types: primary healing, which is also referred to as healing by first intent or intention; secondary healing, which is also referred to as healing by second intention; tertiary healing is also referred to as delayed primary closure. So these are the three types. So in primary intention, as you can see, the wound edges are approximated by sutures, or they can be approximated by staples. Most of the times these wounds heal much faster, and there's not so much of the scar tissue that may form, or the connective tissue is not quite a lot. Usually the scar is small because you have approximated the wound edges. Then in secondary intention, you don't approximate the wound edges and you allow the wound to actually heal naturally. For example, if there's an infection that is here, you allow it to actually heal by secondary intent. Here, of course, there's going to be healing by contraction and epithelialization, while as in primary intention, there'll be epithelialization and connective tissue repair. Then tertiary wound healing is where you delay the suturing for some time. Then after that, you can suture after some time to approximate the wound. So healing by primary intent, like I said, if the staples or sutures are used to close the wound, it's referred to as healing by primary intention. So this is done with clean incised wounds or surgical wounds after someone goes for an operation. So the wounds are going to be approximated by sutures, and the healing is going to be more by epithelial regeneration than it is by fibrosis. It happens rapidly with complete closure. The scar is linear, smooth, and supple. Now remember that the tensile strength is achieved roughly at around 3 months, and generally it's going to be 70 to 80% of the normal skin. Scar tissue cannot have the equal tensile strength as normal skin or normal tissue because it has been damaged. It will lose its maximum tensile strength, so it will be roughly around 80%. Then healing by secondary intention. So here the wound with extensive soft tissue loss, for example, major trauma, burns, even wounds with sepsis, the edges are not going to be approximated with sutures. Then the granulation tissue is supposed to fill in that defect. So these are going to be healing slowly with fibrosis. So it leads to a wide scar, often which may be hypertrophied and contracted. It may lead to disability or contracture. Then reepithelialization is going to be occurring from the edges, from the remaining dermal elements, as well as the wound margins. Then you have tertiary wound healing, which is after the wound is debrided and the infection is controlled, then you actually close it by sutures or you cover it with a skin graft. So the primary contaminated or mixed tissue wounds heal by secondary intent. So we also refer to this as delayed primary closure. So you have to take note that the average wound usually achieves approximately 4 to 8% of the expected tensile strength after 1 to 2 weeks. Then when it's completely healed, it will be 80% of the tensile strength as compared to the uninjured tissue. Now, what are the stages of wound healing? There are predominantly 4 distinct stages in normal wound healing. Some books will give you slightly more, but I find this much easier to actually remember and think about. So whenever you cut yourself, remember that the first thing that's going to be going there is to stop you from exsanguating, from you draining or losing all your blood. So there is some coagulation that has to take place. This happens almost immediately. So within a few hours, within a few minutes, coagulation and hemostasis should take place. At the same time, there should be now these inflammatory cells that have gotten to the site, and they're supposed to be pretty much helping in beginning the process of wound healing and beginning the process of inflammation. So some people actually say that these two stages actually do occur simultaneously, but inflammation will actually reach its peak within the first week. Then after that, you should also get some cells that are now meant to repair this damaged tissue or replace it with connective tissue. So pretty much your fibroplasia and proliferation. Then the structure that has been added there has to be modified so that it appears almost near normal or how it was before the injury actually came. So these are the 4 predominant stages of wound healing. So you have a stage of coagulation or hemostasis, a stage of inflammation, a stage of fibroplasia or proliferation, and a stage of remodeling. So now let's go into details about each of the following stages. So beginning with the stage of coagulation and hemostasis. So this, like I said, happens almost immediately. So when you cut yourself and you injure a blood vessel, the clotting cascade is going to be initiated. But initially, there's going to be this initial transitory or transient vasoconstriction that happens. It's like a spasm. It's like a reflex that the blood vessels undergo to prevent you from losing even more blood. Then eventually there's going to be some vasodilatation so you can bring more inflammatory cells to that area, so you can bring more platelets. What you're going to form is what is known as an initial platelet plug, which eventually is going to lead to activation of the clotting factors to convert this into a definitive hemostatic plug as healing is continuing to go on, and then eventually this clot would have to be dissolved by the fibrinolytic system. So remember that coagulation and the complement cascade are going to be activated. The platelets will create this hemostatic, the final plug. Then there is going to be release of certain various inflammatory mediators from the activated platelets that actually set the stage for the subsequent steps that follow in wound healing. One of the things that's going to be released is platelet-derived growth factor. And like I said, there is an initial phase of vasoconstriction, which is later on followed by vasodilatation to initiate the inflammatory stage. And remember that this stage is impaired by giving this patient anticoagulants, giving this patient antiplatelet agents, if this patient has coagulation factor deficiency, it may be impaired. It's also impaired in the setting of chronic liver disease and other conditions like uremia. Then you get into the inflammatory phase, which is pretty much now from day 0 to about day 4 to day 6. So I can say within the first week. So here, this is going to be beginning with vasodilatation. Remember that the first cells to actually get to the site of the infection are usually your neutrophils. Then this later follows the macrophages. These are meant to remove any tissue debris that is there, because healing cannot take place if there's any foreign body that is stuck in the wound. Now, the lymphocytes are going to be recruited later, and if they persist, this may lead to chronic inflammation. So this shows features of inflammation. So the rubor, color, tumor, dolo, and functiolasa, which is pretty much redness. There should be swelling, there should be pain, there should be warmth or heat, and there should be loss of function. So this is just in Latin translated to English. So the macrophages are going to be producing what is known as fibroblast growth factor. So this is going to enhance angiogenesis, the formation of new blood vessels, as well as skeletal development. The polymorpho nuclear lymphocytes are going to appear after 48 hours, and they're going to be secreting inflammatory mediators. They're going to be secreting bactericidal or oxygen-derived free radicals, and they also remove the blood clots, the foreign bodies, or any bacteria that is present. Remember that there are some chemical factors that are going to be associated in wound healing, some growth factors, including transforming growth factor alpha and transforming growth factor beta. So the alpha variant is going to be involved in epithelial and fibroblast growth. The beta is going to be involved in fibroblast growth, as well as it inhibits inflammation. You may also have the platelet-derived growth factor, which I already talked about. So this is, of course, derived from the endothelium, the smooth muscles, and it's also a fibroblast growth factor. Then the fibroblast growth factor stimulates angiogenesis and skeletal development, and the vascular derived endothelial growth factor is pretty much needed for angiogenesis. Then you get into the next stage, because you're producing all of these cytokines that are supposed to stimulate these cells to now replace the tissue that was damaged. So in the stage of proliferation, or the fibroblastic stage, this is where there's going to be granulation tissue. So this takes roughly from day 4 to about 3 weeks. So from day 4 to about day 21. This granulation tissue is going to now be consisting of predominantly 3 things. So number 1, there's going to be fibroblasts. Remember that these fibroblasts are going to be depositing type 3 collagen. It's initially type 3 collagen that is supposed to be deposited, then later on changed to type 1 collagen. So remember that there are 4 predominant types of collagen that I want you to keep in mind. So type 1 is found in bone. So remember, bone has a 1 to help you remember that type 1 collagen is found in bone. Type 2 is found in cartilage. So just remember cartilage. Type 2 is found in cartilage. Type 3 is the one that's found in the blood vessels. It's found in granulation tissue. It's found in embryonic tissue. It's found in the skin because it has a pliable characteristics. Then type 4 is found in the basement membrane. Then also capillaries are going to be forming to provide the nutrients. Myofibroblasts will also be present for the wound contraction to actually bring the wound edges closer to each other. Remember that the presence of granulation tissue is going to be a reassuring evidence that the healing process is actually undergoing in a nice manner. And remember that there are features of healthy granulation tissue that you must know. And at 1 month post the injury, the wound is actually going to be about 85% of its ultimate cohesive strength. Remember that collagen synthesis is occurring in the fibroblast and is pretty much going to be in the presence of certain things. So the amino acids, hydroxyproline as well as hydroxylysine, are actually very important components of collagen. And their synthesis and hydroxylation is going to be dependent on certain things. It's going to be dependent on iron. It's going to be dependent on alpha ketoglutarate. It's going to be dependent on ascorbic acid, which is vitamin C, which is why when you see patients on the surgical ward that have wounds, we often give them vitamin C, because vitamin C is a very important thing in collagen synthesis. Then the angiogenesis is going to be taking place. So this occurs in response to certain peptide growth factors, such as vascular endothelial growth factor. Then the presence of these new vascular networks is what actually gives the granulation tissue its characteristic beefy red appearance. Epithelialization is also going to be taking place. So this occurs where you have migration of the epithelial cells over the wound defect. Then of course you're going to be having integrity of the basement membrane being restored, where you have type 4 collagen and even the matrix components being deposited. Certain foreign bodies such as the suture materials, necrotic tissues that remain separated from the wound by the migrating epithelial cells. So once this step has occurred, then the wound is essentially waterproof. So water is not going to be able to penetrate this area. Then you have the stage of remodeling, which happens from week 3 to about 18 months. So this is the stage of maturation. So the collagen actually matures. So there's cross-linking of the collagen, which actually gives the tensile strength to the scar. Then of course there is also differentiation of the fibroblast into myofibroblast for the wound contracture. And remember that collagen production is not present after 42 days of wound healing. Then the type 3 is supposed to be replaced by type 1. Remember that what is responsible for this is an enzyme that's referred to as collagenase, which actually requires zinc as a cofactor, which is another reason why we do give zinc to our patients, zinc sulfate, to our patients that have wounds, because it helps in wound healing. Then the process results in wound healing by an epithelialized white scar, and the maximal tensile strength is achieved at about day 60, which is about 80% of the normal tissue. Then what are some of the factors that actually delay wound healing? You can divide them as local factors as well as systemic factors. Local factors include infections. This can actually delay the wound healing. So this is actually the most common cause. Presence of necrotic tissue or foreign bodies, poor blood supply, wounds that are on the back are not going to heal so quickly, venous or even lymphatic stasis, tissue tension, hematomas, large defects or poor apposition, recurrent trauma, x-ray of the irradiated areas, site of the wound. So if the wounds are carrying over joints which are constantly moving, and even at the back they heal very poorly. And then of course any underlying diseases like osteomyelitis and malignancies, mechanism and even the type of the wound, incised wounds versus lacerated, crushed or avulsed wounds. You may also have tissue hypoxia locally, which is going to be reducing the macrophages and fibroblastic activity. Then there are some general factors or systemic factors: age, obesity, smoking, malnutrition, zinc deficiency because it's needed for collagenase, copper deficiency, it's needed for lysyl oxidase, and manganese deficiency. You may also have some vitamin deficiency like vitamin C for the hydroxylation of collagen as it matures, and vitamin A. Hypoproteinemia, anemia, malignancy, uremia, jaundice, diabetes, metabolic disease, HIV and immunosuppressive diseases, steroids and cytotoxic drugs, neuropathies of different causes, emotion and even physical and psychological stress are factors that actually delay wound healing. Then what are some of the complications of wound healing? You may have early complications: dehiscence, which is rupture. It's the most commonly seen with abdominal surgery. Compartment syndrome, which is I think I have talked about on the channel. Intermediate complications include wound infections. Late complications include hypertrophic scars, where there is excessive production of scar tissue that is localized within the margins of the wound. Then you may have keloids, which are excessive production of scar tissue out of proportion of the wound margins. So here there is excess type 3 collagen. There is a genetic predisposition, much more common in African American individuals, and it classically affects the earlobes, the face, as well as the upper extremities. How do we manage these wounds? So generally we want to inspect the wound and classify it according to our surgical classification. If it's in a vital area, do your ABCs. So ensure that the airway is maintained. If there's any bleeding, control the bleeding. Apply pressure, suture any blood vessels that are torn. If there is intravenous fluids that are present, give these intravenous fluids. Then of course get blood if they need some blood transfusion. If they need oxygen, give them oxygen. Then for the deeper communicating injuries and fractures, we should look out for those. Get some imaging to actually have a look out for those. If it's an incised wound, then primary sutures should be done after, of course, thorough cleaning. Clean it as much as possible with normal saline, as much as possible with iodine before you suture it up. So primary suturing is done usually within 6 hours. It's done for clean incised wounds. Then primary suturing should not be done if you have edema. Do not do it if there's an infection, if there's devitalized tissue, if there's a degloving wound, if there's any hematoma. Do not perform primary suturing. Then always look for these associated injuries of deeper structures like vessels, nerves, tendons, and they must be actually repaired before you actually suture up. So the wound should be widened by extending the incision whenever you have poor evaluation of the deeper tissue, so that you can get a proper evaluation. Properly clean this wound, debride this wound and excise any tissues that is dead, remove any foreign bodies that are present before you close it. And of course, the skin closure, if possible, without any tension. You shouldn't have any tension on the skin because it will become necrotic. Skin closure by grafts or flaps can be done in the immediate or even delayed. Then the untidy wounds should be made tidy and clean before you actually suture them off. Then proper aseptic precautions should be undertaken. Cover them on antibiotics and analgesics as needed. Cloxacillin 500 milligrams 4 times a day orally. Metronidazole 400 milligrams 3 times a day orally. Plus maybe a diclofenac to help for the pain, or paracetamol, depending on the extent of the wound. Then of course, suture the wounds, or the sutured wounds should be inspected after 48 hours or within 48 hours for the neurovascular state. And generally you can remove the sutures after 7 days, but this largely depends on the site of the wound, because different areas have different times of where you should actually remove the sutures. So this 7 days thing is not something that is set in stone. And if it's a crushed or devitalized wound, there will be edemas, there will be tension in the wound. So after the wound debridement or the wound excision, then all the devitalized tissue should be removed. The edema is allowed to subside within about 2 to 6 days, because we know that this is when the inflammation is actually going to be taking place. So the delayed primary suturing is going to be done. Remember that delayed primary suturing means that suturing the wound in 48 hours up to 10 days of the injury. Then it's done for the lacerated wounds, so you can allow time for the edema to actually subside. Then if the wound is actually a deep devitalized wound, after you debride the wound, you should allow it to completely granulate. Then later, if the wound is actually small, then secondary suturing can be done. Then if the wound defect is still large, you can actually put a split skin graft over the defect. Then in a wound with tension, you can do a fasciotomy to actually relieve the pressure and to prevent compartment syndrome from developing. And remember that vascular or nerve injuries are going to be dealt with accordingly. So the vessels should be sutured with 6-0 Proline non-absorbable sutures. And if the nerves have been cut or a clean cut, they should be sutured primarily with a Proline 6-0 or 7-0. And if there is difficulty in identifying actually the nerve endings, and if there is actually crushed, cut nerve endings, then marker sutures should be placed with silk at the site, and later secondary repair of the nerve can actually be done. Then with the internal injuries like intracranial by craniotomy, intrathoracic by intercostal drainage, and even intra-abdominal by laparotomy, these should be dealt with accordingly with what I've already mentioned. Any fracture of the bone should also be identified and managed as per fracture. Then cover this patient on antibiotics. Fluid and electrolyte balance is important. Blood transfusion if they need be. Remember, if someone has an HP less than 10, the wounds heal very badly. A tetanus toxoid, that's a 0.5 mils intramuscular injection over the deltoid. You may also give anti-tetanus globulins around the wound if you're suspecting that this person may have been exposed to tetanus. Wound debridement and wound toiletry or wound excision is just simply liberal excision or cutting out of all devitalized tissue at regular intervals. So that's about 48 to 72 hours until the tissue is healthy, it's bleeding, this vascular tidy wound. And once you've created this, then you can actually either suture it up or you can actually put a skin graft. So wound toiletry is going to be done with washing the wound thoroughly with normal saline, ideally. Then the wound debridement is allowed to allow content to come out, but of course performing some releasing incisions, some fasciotomies, but commonly debridement is used for a wound excision. Then once you do this, remember that the wound excision is actually the correct terminology for excising any devitalized or removing any devitalized tissues, or even once or even serially. And then radical wound excision, which is a pseudo-tumor approach, is just simply excising entire devitalized tissue and just leaving tissue with visible bleeding from all the layers. So you cut off all the dead tissue until you can see that this is now bleeding and it's normal tissue. Now here's, just before I close this lecture, difference between incised wounds and lacerated wounds. So as you can see here, you have an incised wound with irregular margins and lacerated wounds with jagged edges. So here's a difference. So in lacerations versus incised wounds, lacerations, blunt force or trauma, these are usually sharp force or trauma. Then lacerated wounds, the edges are ragged or irregular. Here they are cleanly divided. There is some bruising in lacerated wounds, no bruising in incised wounds. The depth is variable with lacerated wounds and it's uniform with incised wounds. Then there is presence of bridging tissue in lacerated wounds. You don't see this in incised wounds. Then the position is usually particularly on the bony prominences. It can be on any location with incised wounds. Then the presence of foreign bodies, usually the contaminated wounds in lacerated wounds, and they're usually clean with incised wounds, unless maybe it's glass that you find in that area. Then intact hairs may cross the wound in lacerations, then the hairs are actually cleanly divided in incised wounds. Then bone injuries may be present with lacerations. Then with incised wounds, it may be chipping of the bone that may actually be seen. Remember that lacerated wounds heal by secondary intention, so with extensive scarring. Then incised wounds heal by primary intention, so it's good if the wound edges are actually approximated. Another thing that you should be able to distinguish between is excised wounds versus incised wounds. So remember that excised wounds are pretty much injuries caused to the tissue through the act of cutting out normal tissue or cutting out tissue from the body. Then incised wounds are injuries created by the act of cutting into the tissue. So remember the difference. Excised is cutting out, incised is cutting into. So here's a warm-up question. Factors that delay wound healing include A, poor blood supply for nutritional support. This is true. B, infection, which is true. C, poorly controlled diabetes mellitus. This is true. And then obviously that will make D as false. I really hope you enjoyed this lecture on wounds and wound healing. If you did, consider subscribing to the channel. Hit the bell notification icon to be receiving notifications of such amazing contents every time I post. Drop a like, drop a comment. To Zambia and beyond, my name is Dr. Moses Kazevu. Until next time, bye-bye.